So that's very important. Without further ado, I'd like to introduce my friend Bill Schaeffer, who's an oral maxillofacial surgeon, works in private practice in London. He has experience with all major implant systems and has used Bicon for the last 7 years. Bill. Well done.
Hi, good afternoon. I've been placing Bicon implants for 7 years, and I have made loads of mistakes placing them. But most of the mistakes I've only made once, and I've learnt from them, and I've avoided them again. But there have been some problems that I've had that repeated themselves. Despite my most careful effort, the same errors happen time and time again. And it's taken me a long while to work out why those problems occur and how to avoid them. And that's why I'm here speaking to you today, so that you can learn from my mistakes and drill perfect Bicon osteotomies every time. Particularly in the two following situations where I had lots of problems, drilling on a sloping bony surface and drilling into extraction sockets in the aesthetic zone. Got a lot to get to, so I'm going to move straight on to drilling on a sloping bony surface. Now here is a sloping surface. Doesn't just have to be a mesiodistal one like this. You can have any sloping surface. It's all relevant. And if we focus in on this, we'd like to place our crown in this position, which means that we'd like our implant to be centered on that crown. And so we'll start our osteotomy by drilling with our sharp-pointed pilot drill, running fairly fast, 1100 revs, and we're going to end up with a pilot hole centered exactly on that crown position. Now we line up our 2.5mm reamer burr, and this is where the problems begin, because this is not a spiral twist drill. It is not running fast. It's running at 50 revolutions a minute or less, and it's only got 2 cutting surfaces. And when you line it up with your pilot hole, it will only contact the bone on the uphill surface. And when it starts rotating, it'll move from this position to that position. I'll go back and forwards again. It's a very subtle movement. You won't even feel it happen. But we've moved downhill with a reamer burr, and now when we drill down, it's got bone on both sides of this reamer burr, so it won't move any more downhill, and you will be able to drill your osteotomy straight down. But if you look at this picture, the shaded portion has already been drilled. You're only removing bone from the downhill side of your osteotomy. In other words, the whole osteotomy is beginning to move in the direction of the red arrow. And you'll come and you'll line up your 3mm reamer burr, and you'll line it up with the middle of the hole. You probably won't even realize that that's not the center of your planned crown position, because your osteotomy has already started to slide downhill. But you won't notice that, and you'll start drilling. And again, when it rotates, it'll move downhill, because it's only contacting bone on the uphill side of this hole, and it's going to move from there to there. A movement you won't even notice, and you'll start reaming. And when you ream, the shaded portion has already been removed, and the only bit of bone that you are removing is from the downhill side of the osteotomy. Every time you go up with a reamer, you'll just take bone from downhill. What will that mean? It'll mean that instead of your osteotomy being in the dark dotted line, you've got the osteotomy well downhill. That was where you wanted the center of your implant to be, but that's the center of your actual osteotomy. Okay? And hopefully you can see from this, something that we're going to come on to time and time again in this presentation, is that when drilling on a slope, the pilot hole stays where it is, and everything else gets removed from the downhill side. So the pilot hole becomes the uphill margin of your final osteotomy. And if your osteotomy is going to look like this, and your crown and your implant are going to look like this, you're going to have a mesially cantilevered crown off an implant. Okay? That's the center of the crown. That's the center of the implant. And if you don't think this happens, I've just taken the following cases off the Bicon website. A crown cantilevered mesially off an implant that's been drilled on a slope. A crown that's cantilevered mesially off an implant drilled on a slope, and a crown that's cantilevered mesially off an implant drilled on a slope. Of course, it's going to be more noticeable in the bigger, the wider, the 6mm diameter implants, because you've slid more downhill. Okay? Now, it's much easier for me to show you these things on models, not only because there's no blood and saliva, but because I can screw up as much as I want without having to worry about the patient, okay? I've taken a plastic model and I've ground down one side so we have a sloping surface to drill on. And I'm going to drill a pilot hole. It's my pilot burr. And if we look down, that's the pilot hole, and I'm going to mark with a pencil right on the middle of that. And that's with the pilot drill in, and I'm now going to do some reaming. 2.5, 3, 3.5, all the way up to 5 millimeters. And you can see that we slid downhill from the pilot hole that has remained uphill. Everything else is removed downhill, and that's the center of your final osteotomy. We've slid in the direction of the red arrow. Now, if we know that that happens, how can we avoid it? There are only 3 ways to avoid it. The first is brute force, okay? It's not a good technique, all right? If we know that that's where we're going to center our osteotomy, and we center our pilot hole here, if we know we're going to move downhill with the reamer burrs, we can lean on them. We already hold the handpieces usually like a bat, like a club, and you can really put some force on them, and you will end up drilling a straight osteotomy. Is it a good technique? No, it's an awful technique. Why? Because it's bad for the reamer burrs, you're going to blunt them quickly. It's bad for the handpieces, you're going to burn out those bearings, and it's really bad for the bone. You're going to heat it up. So if that's a bad technique, what are the 2 good techniques? The first one was taught to me by Shadi Daha, and that's if you know you're going to slide downhill from the pilot hole, start the pilot hole uphill. So if you know that's where you want the center of your final osteotomy to be, start the pilot hole uphill. How far uphill? Well, we've already seen that when drilling on a slope, the pilot hole becomes the uphill margin of the final osteotomy, so that's exactly where you want to start it, just a little way uphill. When you come with your reamer burrs, you will slide downhill and your implant will be centered exactly where you want it on the crown. It's a great technique because there's no wear on anything. And there's no extra bits of equipment. But the downside is it's impossible, or hard, if not impossible, to use with a drill guide, with a stent. The stents have a groove marking the middle of your intended crown position, and yet you're having to drill the pilot hole uphill from that. So it's very hard to use. So perhaps it's one for experienced users who aren't so reliant on stents. What's the third way? It's to countersink the pilot hole. I have to thank Rainier Erdnetta for telling me this technique. And I love it, and I use it for almost every implant that I place. What do I mean by it? Well, we've seen these pictures before. We drill our pilot hole, centered on the crown position, and we then take a big round burr, and we countersink the hole. What burr do I use? I use a burr and a latch reamer handpiece. Sorry, a latch handpiece. You can see it's a fairly aggressive burr. It's a cross-cut burr. You can get these burrs from any dental supplier. I use it in the 1-to-1 handpiece. I have it running as fast as my motor will let it spin with some cooling irrigation. And I can hear some of you thinking, well, hang on a sec, 30,000 revs, but our pilot burr only runs at 1,100 revs, and we have it running only that fast so that it doesn't heat up the bone. If you have it running 30, 40, or 50,000 revs, you're going to burn the bone, the implant won't integrate, it's going to be a disaster. That will never happen. We're not talking about a long, narrow pilot burr that you bury way down deep in the bone, well away from any cooling irrigation. We're talking about a burr that is always at the surface, always accessible to the cooling irrigation. It's a big hunk of metal. It transmits temperature quickly. You've got to have it running fast because it's a wide burr. If you have it running slow, it'll just bounce you out of position, okay? You want it running as fast as your unit will allow so that where you touch the bone's gone, disintegrates. And then you can be really subtle, really delicate, and place your countersink exactly where you need it to be. What size burr is it? I use a 4mm diameter burr. And again, I can hear some of you thinking, well, hang on a sec, what if you want to use a 4.5mm diameter implant, or a 5mm implant, or a 6mm implant? Do you need separate burrs for each one? I have separate burrs for each one, and I never, ever use them. I only ever use a 4mm burr. And if I want to go wider, all I do is I jiggle it about a bit. And I know that doesn't sound scientific or precise. It's incredibly precise. Why? Because if you've got a reasonably narrow ridge, and you've got this burr spinning fast, 4mm, you make a 4mm diameter countersink, and you look at the ridge. And you can look, and you can see easily, do I have bone either side of this 4mm hole? If you do, you just wiggle it around a little bit wider. It's very, very easy to make subtle changes. You can see from this picture that you have taken more bone away from the uphill side of the hole than the downhill side of the hole, and that's the whole key. Now, when you put the reamer burr on, it's got even bony contact either side. It'll drill straight. When you go up a size, even bony contact either side. And not just uphill and downhill, 360 degrees around this reamer burr. So it's going to have smooth bony contact, and we'll come on to that in a moment. You're going to end up drilling straight, your implant straight, you're going to have a great crown position. Here's the other side of the model, and again, I've drilled it down so there's a sloping bony surface, and I've drilled my pilot hole with my pilot burr. That's looking end on the pilot burr, and that's looking in the hole. I now take my 4mm countersink burr, and I drill a 5mm countersink. And it's a little bit hard to see. Maybe from this angle is the best one. You can probably see that I've drilled away more from the uphill side than I have from the downhill side. And that automatically happens when you drill over your pilot hole. I've now put the pilot burr in simply so that I can mark neatly the center of this pilot hole so that you can see where it's centered. And if we look laterally, it's roughly centered over that pilot hole. I'm not going to go through all the intervening reamer burrs. I'm just going to go straight up to the 5mm. And you can see that it's pretty central on that view. It's much easier to see. You can't fool with camera angles this view. You can see that I am dead center. Now, this next bit is important. You have to take my word for this. I can't prove it to you. But I was not holding the handpiece like a club, like a bat, tucked into your side and leaning in. I was holding it like I hold an air rotor, like I hold a high-speed drill, like I hold a pen, gently, subtly. You don't need to grunt out these osteotomies when you do this. And you can see that we're dead center. Even though we're drilling on a slope and I'm holding it like a pen, the osteotomy gets centered on the countersink. The downsides of this technique are that you need extra equipment. One burr, one handpiece. Your reaming will be so much faster afterwards that you'll save so much time. There is less bone to collect in the flutes of the reamers because you've drilled away some of the bone, but your implant's going to be perfectly positioned. When you do this, you won't need loads of bone. There isn't any wear on anything, which is always nice. And this next one, really important. Anyone that's drilled a Bicon osteotomy using the Bicon reamers, they know that you have to fight the handpiece. It bucks and kicks and jerks around. Patients hate it. Dentists, I hate it. And that's why we're taught to hold the handpiece like a club. It's not very subtle, but we're taught to show that reamer burr who's boss. Because you have even bony contact with the countersink all the way around the burr, you will be funneled down into the middle of the countersink. Okay? Every time. Effortless, smooth, no jerking. Now, there are so many other advantages to this technique, but the one of them that I'm going to go into briefly is that you can correct the position of the pilot hole without any effort at all. We've all drilled a pilot hole, looked at the alveolar ridge and gone, I wish that was just a millimeter or two mesial, distal, buccal, lingual, whatever. Okay? You can't drill another pilot hole right next to a pilot hole you've already drilled. Just slide into it. Okay? This technique, easy. Here's another plastic model that I haven't ground down into a sloping surface. This is a flat surface, and I've just marked with a pen on the middle of the ridge. And I've made a red circle that's 6mm wide. Because for this demonstration, I would want to put a 6mm implant in. I wouldn't normally clinically, but just to show you how powerful this technique is. And I'm now going to screw up as much as I can with my pilot hole. I am as far on the edge of that 6mm circle as I can possibly be. All right? If we look at it without the drill, it's a bit easier if I put a little pink dot over the top of it. But you can see that is right on the edge of my eventual planned implant position. Does it bother me? Not in the slightest. I take my countersink burr. It's 4mm in diameter, the countersink burr. I drill a 6mm diameter countersink. Okay? If we look close up, you can again see the pilot hole is way off to the side, as far over as it can be. Doesn't bother me at all. I pick up my 400:1 handpiece. I hold it like a pen. That is a 2.5mm reamer hole, 3 reamer, 3.5, 4 reamer. That's a 4 reamer burr. That's a 4 reamer hole. Oh, sorry, it's 4.5 rather. This is a 5 reamer hole, 5.5. 6mm reamer. Look at the position. Effortless. Wasn't holding it like a bat. Take a look, close up. There's red pen on both sides of this. Buccal and lingual, all right? No wear on any bits, no having to force the patient. All right, this will happen every single time. It's a very, very powerful technique. These are the before and afters. I love it. I use it for almost every osteotomy that I drill now. But there are some osteotomies that you can't use it in. You can't use it when you're drilling into sockets in the aesthetic zone, which was another one of these repeatable mistakes that I kept ending up with my implants way too labial. Obviously, this is also called immediate implants in the aesthetic zone. And I want to make it very clear that what I'm talking about is only situations where you take out a tooth and you've got a bony socket all the way around. So use periotomes, use luxators, however you want to do it, but I'm only talking about situations that aren't dehiscences, aren't fenestrations. And whenever I've taken a tooth out and I have that intact bony socket, I've always looked on that and thought, this is the perfect starting point. I've done the hard bit, I've taken the tooth out beautifully. This is a blank canvas for me to paint on. And I should be painting a masterpiece every time, and I wasn't. When you have a tooth and you take it out in the aesthetic zone, you have a very, very thick palatal wall of bone, and you have a really thin sliver of bone labially. If you don't think it's as thin as that, that's the apex of the socket. That's the thin labial plate, and look how thick it is palatally. Again, another one. That's the apex. That's the thin labial plate, and you've got the thick hunk of bone palatally. And again, with the canine, apex of the socket, thin labial plate, and you've got a thick hunk of bone palatally. We all know that when we take out a tooth, we don't drill straight down the middle, the apex of the socket, because we've seen the Bicon cartoons that show us that we will blow out the labial wall. And so we know that we have to drill into the palatal wall somewhere. We come up a little bit from the apex. But no one's ever stated how far up. And so what I used to do was I used to come up about a quarter of the way. I used to think that was right. And I used to do what Bicon taught me, which was come in with my pilot burr at an angle, gain a bit of purchase, upright it. Upright it to where? Well, upright it to between the contact points, and drill my pilot hole. The moment my burr touched the bone, I was destined to have a bad implant. All right? It was always going to be in the wrong position. Why? Because from here on, we're going to be drilling on a slope, and it's a really steep slope. Okay? We know that when we do this, our reamers are never going to end up going uphill. They're only going to end up going downhill, and that means that our final osteotomy is going to be there. Look how thin the labial plate is. If we put an implant in, that's the biggest implant we're going to hope to get. You daren't go any wider with the osteotomy because you can already feel the reamer bending, bowing that labial plate, and it's already thin enough. If that's the biggest implant we can possibly get in, then it's always going to have a 2mm post. It's almost always going to be an angled abutment. Do we like 2mm posts and angled abutments in the aesthetic zone? No, because they come out more often. All right? And look how thin the labial plate of bone is. Often you have to sink these way down deep in order that the angle change can actually get you somewhere that's restorable. And yeah, you can do clever things with IACs, and you can end up with them looking kind of acceptable with the pink IAC material, but that's not what I want to end up if I'm given that perfect starting point of an intact bony socket. I don't want to end up like this. The masterpiece that I want to paint, if I'm given a blank canvas, looks like this. You put a crown on it, that's what I want to achieve. Why is that the perfect implant? Well, first of all, it's a big implant. It's a 5x11 for laterals, or 4.5x11 for centrals, every time. And I know Vin will say, you don't need to go so long, you can put a 5x80 and it'll carry any tooth in the mouth. And he's quite right, but we're drilling into a socket. So most of the top part of this implant is going to be surrounded by socket, blood clot, air. All right? And I want to go down, put an 11mm implant in, because then at least I know that the apex of that implant is surrounded by good, healthy bone. And it will allow me to harvest more bone, which you'll see what we do with later. Why else is it a perfect implant? Well, if we're using implants that size, it's always going to be a 3mm post, every time. And if it's in that position, you're going to have a 0-degree abutment every time. Do we like 0-degree abutments and 3mm posts in the aesthetic zone? Yeah, that's all we ever want. All right? I've put here that I use a stealth abutment, and that's because I will always want to try and immediately stabilize these. All right, put a restoration on straight away. I've also written that I want to use a 5x4 stealth abutment every time. And again, I can hear some of you thinking, well, it's going to be hard enough knowing what implant you're going to use, let alone what exact abutment you're going to use before you've even drilled the hole. I've been doing this technique that you're about to see for a year. I haven't used any other implant. I haven't used any other abutment. I know every single time. I only take out the box one abutment. It's going to be a 5x4 0-degree abutment every single time. And you'll see how you can achieve that in a moment. What else is good about this implant? Why is that the position that I want? It's all to do with the labial plate of bone, all right? Especially over the shoulder. Why? Because of the blood supply to the labial plate. When you have a tooth and that really thin labial plate, that thin bit of bone has two blood supplies only. A blood supply from the periodontal ligament and a blood supply from the gum, from the periosteum. It has no significant blood supply from within the bone, endosteally. Why? Because that thin little bit of bone is two cortical plates fused together. There's no cancellous bone in there, so there's no endosteal blood supply. Obviously, if you take out a tooth, you lose one of those two blood supplies to that bit of bone. And the only blood supply left is from the gum, from the periosteum. Clearly, if you put an implant in there, if that bit of bone only has one blood supply from the gum, it's not going to take a lot of an insult to the gum, bit of gingivitis and toothbrushing trauma, to interrupt that blood supply, the only blood supply for the bone, and you're going to begin to get recession. And let's face it, it's not a very thick bit of bone to recede. It's a thin sliver, and it's going to get lost. I want my implant here with a thick bit of bone, not only because it's a bigger volume of bone that would have to be lost in order to get recession, but more importantly, because if I've made that bone thicker, then I will have cancellous bone within it and an endosteal blood supply. That means it's got dual blood supply. You can have as much gingivitis as you want. You can have as much toothbrushing trauma as you want, and the bone is still going to be perfused with blood endosteally. And so if we come in 20 years' time for the 40th anniversary of Bicon, I hope to be able to show you pictures that have fairly stable gum margins. If that's the implant we want to achieve, how do we get it there? Well, we're going to be drilling on a slope. We know that when drilling on a slope, the pilot hole becomes the uphill margin over the final osteotomy. What does that mean? Well, if that's the implant and the crown that we want, that's the position of the implant in the socket, the only place that you can have your pilot hole is here. The only place. If you have it any more down the socket, you're going to end up with narrower implants or crowded up against the labial plate. Where does that pilot burr enter the socket? It enters the socket here. 3/4 of the way up. Now, that's way more than I used to do. I used to come up 1/4 of the way, 3/4 of the way. That is the only position that you can start your pilot hole if you want this perfect implant. You must start the pilot hole 3/4 of the way up the platal wall or the bony socket. Now, one important thing to remember is it's the bony wall of the platal socket. I've made the mistake of going from the apex of the socket to the edge of the gum, but sometimes you've got really thick gum. And so 3/4 of the way up, that is in the gum. It's 3/4 of the way up the bony wall. And if you do that, you'll end up with a beautiful implant. Now, how do we drill this? I don't want to drill it in the classical Bicon technique of coming in with my pilot burr at an angle and uprighting it, because I'd be too worried about going all the way through. It's too easy to do. I want to have a little bit more control than that when I drill my pilot hole in this situation. So how do I do it? I start off with a little dent, 3/4 of the way up the wall. What do I use? I'm a surgeon. So I use a surgical burr, surgical handpiece. This is just a surgical round burr. And I simply put it into the socket, and I simply move it platally, make a dent. And when I drill that dent, I come in with the burr at that angle. But when I come out with my burr, I come out from the dent in that angle. And why? Because I want to get rid of this bit of bone. Why? Because I want to end up with a ledge like that. And the reason is that I can now lay my pilot drill straight on that bit of bone. I don't have to upright it at all, and I can drill straight down and create my pilot hole. Now, you can probably see from this that the whole while that that pilot hole was being drilled, the burr is touching the soft tissue at the margin of the socket. All right? You must have that pilot burr so upright that it touches the soft tissue. All right? And it's going to look weird. It's going to look like this. That's the end of the pilot burr. All right? Looks like this can't possibly end up with a good result. It's the only way you're going to end up with a good result. If we look in, that is the pilot hole. That's the apex of the socket, and we're 3/4 of the way up. Okay. Bear with me. How deep do we go? Well, we know that we want to put in an implant that's 11 millimeters long. I've explained why. And we know that with Bicon, you bury them at least 3 millimeters below the bone, which is at least 5 millimeters below the gum. And this is an aesthetic region, so I'm going to go 6 millimeters below the gum to the top of the implant. So that means I want to go 17 millimeters deep with my pilot hole. Is there a marking on the pilot burr at 17 millimeters? Well, it just so happens there's a handy marking, which you can line up with your gum, which you're lying right next to. Okay? Once you have got this, you are destined to have the perfect sized implant in the perfect position, every time. You could, if you're of a mind, go and have a coffee and let your nurse finish off the osteotomy, because you're drilling on a slope. You are only ever going to slide downhill with the reamer burrs. So you're going to end up with an osteotomy that looks like this and an implant that looks like this, every time. If you want to see some clinical examples, that's obviously the pilot burr end-on touching the gum. That's the 5mm reamer. Look at where it is in relation to the contact points. Here's a central incisor. That's obviously the pilot burr. That's the 5mm. Look where it is in relation to the contacts. Here's two of them, looking end-on, touching the gum. Now you've got a 4.5 for a lateral and a 5 for a central. Look at the position in relation to the contact points. They're perfectly placed. You've now got perfect-sized implants in the perfect position, but they're not perfect implants yet. We're almost there. What else do I need? I want to graft some bone labially and over the shoulders of the implant. Then we're going to get a perfect result. Now, we know, it's obvious, that if I don't put something in the well of the implant to fill it up before I graft over the top, then my graft material is just going to go straight into the well. Okay? So we have to fill it with something. I can't put my stealth abutment with its acrylic sleeve on, because if I do, there's no room around it to put my graft material around. You can see from here there's just no space. I've tried using guide pins. Don't do it. All right? Why? Because it's got a shoulder on it. And if you pack your graft material on that shoulder and you take the guide pin out, what comes out with it? All right? You only make that mistake once. Here's a clinical situation. You can see guide pins in the implants. If you pack bone over that and you pull out the guide pins, it's going to be a mess. So what do you use? You use your healing plug. It's got no shelf, no shoulder on it. It's a nice smooth taper. It fits the implant well very nicely. And you can see here loads of space around the post to be able to put some graft material. What graft material? Well, because you've gone down and you're going to use an 11mm implant, you've got a load of autogenous bone. There's usually enough space to graft that I tend to mix it with whatever your favorite graft material is. Biowas, Purewas, it doesn't matter. Mix it with something and pack it in. And there you can see it packed in. When you take out the healing plug, you've got access straight away excuse me, for your stealth abutment to go right in. And when you push the post into the well of the implant, the hemispherical base is going to compress that bone graft right over the shoulder, right where we're constantly being told you need your good bone. All right? You're going to end up with a result like this. Here are two. You can see how much room there is around these posts to be able to pack the bone graft. That's the autogenous bone. Mix it with whatever you want. Lay it on the gingival margin and just poke it down. And eventually you'll see your healing plug sticking through. Not bad position for those. Take them out and stick in your 5x4 0-degree abutments. All right? That's the only ones I ever use in this region. Tall, narrow sleeve for a lateral, short, fat sleeve for a central. Coming right to the end now. This is a lateral incisor. Look how far away we are from the labial plate. We haven't encroached on it. And when we've grafted under before we put that on, and look at the bone over the shoulders. Every time. Very final case. Central incisor. You've seen these pictures before. That's the pilot burr. That's the 5mm reamer burr. Look at the space labially that we still have. We haven't encroached on that labial plate. We're going to put in some bone graft. We're then going to put in our stealth. Look at the position. Every time. All right? And look at the x-ray and look at the bone over the shoulders. This technique is so predictable that if you are able to take out teeth with an intact bony socket and you have a blank canvas like this to paint on, you will be able to paint a masterpiece every time. I'd like to thank Bicon for inviting me to speak. I'd like to thank David Hallows, who's done an amazing job on these illustrations. They're just fantastic. I'd like to thank Vanessa, my wife, for putting up with me. And finally, I'd like to thank all of you for your attention. Thank you very much.